In this video, we will discuss the anatomy of the thoracic esophagus, covering its structure, histological layers, and anatomical relations. We will also highlight its clinical significance. To do so, we will start with a brief introduction. Its descriptive anatomy, its anatomical relations, its vascularization, innervation, and lymphatic drainage system, some key clinical notes and applications, and finally a conclusion in order to summarize all the key points. The esophagus is a muscular fibrous conduit responsible for transporting the food bolus. It is located deeply in the posterior mediastinum. Let's start by detailing the descriptive anatomy of the thoracic esophagus. The thoracic esophagus follows the cervical esophagus at the thoracic inlet at the level of T2. It descends through the posterior mediastinum, obliquely downward and to the left, except at the level of the aortic arch, which pushes it to the right. It ends at the esophageal opening of the diaphragm at the level of T10, where it continues as the abdominal esophagus. The thoracic esophagus has a length of 16 to 18 centimeters and a caliber of 2 to 3 centimeters. It also has 3 narrowings: an aortic narrowing, a bronchial narrowing, and a diaphragmatic narrowing, along with a supradiaphragmatic dilation, called the epiphrenic ampulla. The wall of this conduit is flexible, elastic, and retractable, composed of 3 layers. An internal mucus layer, quite solid, of the Malpighian type, with a smooth pink appearance. A middle submucous layer, glandular, thick, and retractable. And an external muscular layer with 2 layers, a deep circular layer and a superficial longitudinal layer. Moving on to the anatomical segmentation of the thoracic esophagus. The thoracic esophagus is divided into 3 segments: a supraazygous aortic segment, an interazyogs aortic segment, and a subazyogs aortic segment. Let's tackle now the anatomical relations of the thoracic esophagus. At its origin, at the level of the superior thoracic aperture, it is limited by posteriorly, the second thoracic vertebra; anteriorly, the jugular notch of the sternum; and laterally, the first rib. It occupies a posterior and median position, making contact with posteriorly and to the left subclavian artery and the thoracic duct; anteriorly, the trachea and the left recurrent laryngeal nerve; and laterally, the pleural domes. The anatomical relations of the thoracic esophagus at its upper segment are: posteriorly, the spine from T2 to T4. That is covered by the prevertebral muscles. And the sympathetic trunk, more externally, in front of the costovertebral joints. Anteriorly, the trachea, the left recurrent laryngeal nerve, and its lymphatic chain. To the right vagus nerve, crossing obliquely, downward and backward, along the lateral surface of the trachea, to reach the right border of the esophagus. The mediastinal pleura and the medial surface of the right lung. The components of the right laterotracheal space, or Barty's space, formed by: anteriorly, the superior vena cava; laterally, the pleura; medially, the trachea; inferiorly, the arch of the azygous vein; and posteriorly, the left vagus nerve. To the left subclavian artery, and the thoracic duct. In front of it, a quadrilateral of Borgheri, limited by: posteriorly, the left subclavian artery; anteriorly, the left common carotid artery; inferiorly, the aortic arch; and superiorly, the left superior intercostal vein. Further laterally, the mediastinal pleura lining a triangle limited by: anteriorly, the left subclavian artery; posteriorly, the spine; inferiorly, the aortic arch. The anatomical relations of the thoracic esophagus in its middle segment are: posteriorly, the anterior face of the 4th thoracic vertebra and the thoracic duct; anteriorly, the tracheal bifurcation and the peritracheal and intertracheobronchial lymph nodes; to the left, the aortic arch, and the left vagus nerve. To the right, the arch of the azygos vein, and the right vagus nerve. Now let's explore the anatomical relations of the thoracic esophagus at its lower segment. Posteriorly, the esophagus is in contact with the descending thoracic aorta, the posterior intercostal arteries, the azygos vein, and the thoracic duct, and the spinal column from T4 to T10, anteriorly, from top to bottom, the left bronchus, the intertracheobronchial lymph nodes, and the heart, precisely at the level of the left atrium, and the termination of the pulmonary veins, through the pericardium, forming the oblique sinus of the pericardium. Laterally, the vagus nerves surrounding the esophagus, the lungs attached to the mediastinal pleura, and the sympathetic chain and the origin of the splanchnic nerves. In its diaphragmatic passage, the esophageal hiatus of the diaphragm is muscular, extensible, and contractile, located at the level of T10, slightly left of the midline, and contains the esophagus, the vagus nerves, and branches from the cardiac, esophageal, tuberous, and phrenic arteries and veins. This opening is in contact with, posteriorly and below, the inframediastinal posterior space and the aortic hiatus. Anteriorly, the tendinous center of the diaphragm and the orifice of the inferior vena cava. And laterally, the pillars of the diaphragm and their openings. Let's delve into the vascularization, innervation, and lymphatic drainage system of the thoracic esophagus. Starting with its arterial vascularization. The upper thoracic segment is supplied by a branch of the inferior thyroid artery. The middle and lower thoracic segments are supplied by branches of the descending thoracic aorta, which are the esophagotracheal artery and the esophageal arteries. The immediately subdiaphragmatic segment, less well vascularized, is supplied by branches of the esophagocardiotuberositary arteries and branches of the inferior phrenic arteries. About the venous vascularization of the thoracic esophagus, its veins drain into superiorly into the caval system, through the diaphragmatic veins and azygos veins, and inferiorly into the portal system, through the gastric veins and splenic veins. Moving on to the lymphatic drainage system of the thoracic esophagus. After an initial relay in the paraesophageal lymph nodes, the lymphatics proceed through a series of relays from the neck to the celiac trunk, with the most important nodes being the laterotracheal lymph nodes, the intertracheobronchial lymph nodes, the portal space lymph nodes, and the gastric coronary lymph nodes. Moving on to the innervation of the thoracic esophagus. The dual innervation from the sympathetic and parasympathetic systems comes from both the vagus nerves, directly and via the recurrent laryngeal nerves, and the sympathetic system, mainly from the thoracic sympathetic. With this in mind, we'll discuss now some key clinical applications by detailing the esophageal cancer. Esophageal cancer is a cancer that develops in the mucosa of the esophagus. The most common type is esophageal squamous cell carcinoma, often associated with alcohol and tobacco abuse. The onset of dysphagia in any person over 45 years old should raise suspicion of esophageal cancer. An endoscopy can be performed to observe any potential tumor and to take a biopsy for further examination. To conclude, anatomy helps understand the severity of esophageal cancers, its deep location within the thoracic cavity, absence of serosa, and multidirectional lymphatic network. This also explains the difficulty of surgical access, given the significant vascular and nerve relations of the esophagus, and the necessity of choosing the surgical approach based on the location of the lesion.